It's a pleasure for me to chair this webinar. So this evening, we are very pleased to have Professor Giuseppe Mancia and Professor Zhang to give us two presentations on the management of hypertension. So my name is Jiguan Wang, and I would chair this webinar this evening. So let me first introduce our first speaker, Professor Giuseppe Mancia from University of Milan. And so as you may see from this slide, his many titles. So he's currently honorary professor of medicine at the University of Milan Bicocca in Italy. And probably in the field of hypertension, almost everybody knows that he chaired so many scientific meetings of the European Society of Hypertension and also the guideline committee of the European Society of Hypertension in the past about two decades. So he published so many papers in clinical management of hypertension, and he has been also to China a few times before the COVID pandemic. So with this online platform, we can also discuss now about management of hypertension. So I do hope that in the near future, Giuseppe can still come to China to give us some new messages on the management of hypertension. So this evening, Professor Mancia will discuss about importance of heart rate measurement and management in hypertension. And some of you may know that he published a very important review on the use of beta blockers in the management of hypertension in the current management of hypertension. So please, Giuseppe, you have 20 minutes presentation. And after Yujing's 20 minutes presentation, we would have time for discussion with two experts from China, Dr. Ma Ziyi and Dr. Song Wei. They are very famous professors in China in cardiovascular medicine. So Giuseppe, please, you have your slides on the screen, please.
Okay. Thank you very much, Mr. Chairman, for these kind words. On my side, it's a great pleasure to be together with very distinguished scientists and to present some data and my thoughts on an aspect of hypertension management, such as what to do with heart rate. Should heart rate be measured and considered for the management of hypertension, or is something which is extraneous, marginal to hypertension management? Next slide, please. Well, I think there are very good reasons for considering heart rate for the management of hypertension, for diagnostic aspects and for treatment aspects, because there is a huge amount of evidence that heart rate is related to cardiovascular and all-cause events. Here you have the original data, but there have been many more studies, and the original data are from the Framingham study. And you can see from this slide, from the Framingham study, that the greater is the resting heart rate value, and the greater is the incidence of coronary disease, cardiovascular disease, and all-cause mortality. Next slide. And there are several individual cardiovascular events and metabolic events which are related to heart rate. For example, the risk of heart failure is associated with the heart rate value, the risk of coronary disease, myocardial infarction, sudden death related to heart rate values. The same for cerebrovascular events, but the same also for metabolic disorders and renal disease, which is, not as well known as the relationship with cardiovascular disease. Next slide, please. Well, here you see, for example, that the greater is the heart rate value, the greater is the risk of developing metabolic syndrome, and the same for diabetes. So the relationship extends to metabolic disorders. Next slide. And this is true for the kidney, as I mentioned before. Here you see, for example, that there is a relationship between a number of markers of kidney disease, for example, microalbuminuria or proteinuria, but also end-stage renal disease. Virtually all markers we have of renal disease are related to heart rate. And you know that renal disease in turn is connected to cardiovascular disease. So there are, very many types of evidence of a very strong and extended relationship of the heart rate values with cardiovascular disease. Next slide, please. And this is true in all demographic and clinical contexts. There have been many studies, for example, looking at what heart rate does in terms of cardiovascular risk in males, females, in the old age, in people with heart failure, in people with dyslipidemias, diabetes. And in all these conditions, heart rate maintains a predictive value as far as the risk of the conditions I showed you before. And this is true, of course, also for hypertension, which is the topic of this meeting, the main topic. Next slide, please. And because heart rate is related to a number of subclinical organ damages, which when progress come out as clinical events. One of the most popular ones today is, for example, arterial stiffness, because arterial stiffness is in turn related to atherosclerosis. The stiffer are the vessels, the greater is the traumatic effect of intra-arterial pressure on the vessel wall, and the greater the chance of developing atherosclerotic lesions. And here you have all data from our group, in which what we did was to look at distensibility of the artery by the relationship, the slope of the relation between arterial diameter and blood pressure in the radial artery and in the common carotid artery. And patients were paced, and you can see that the greater was the heart rate value reached by pacing, the lower was the distensibility on the vessels. And then, of course, next slide, from the clinical, next slide, next. From the clinical point of view, epidemiological data showing that not only in normotensive subjects, but also in hypertensive subjects, the greater is the resting heart rate value, the greater is the incidence of all-cause death, of cardiovascular disease, and of cardiovascular mortality. Next slide, please. Now, the next question, of course, having shown you, I hope convincingly, that heart rate is an extremely important and extended risk factor for cardiovascular disease and death. The next question then is, why is this the case? And these are all information coming from Handbook of Physiology, that is that heart rate puts the heart at disadvantage because of a number of reasons. Increased cardiac oxygen consumption, increased cardiac workload, reduced cardiac filling, increased aortic impedance, and reduction of coronary perfusion, because the time of perfusing the heart is mainly the diastolic phase, and with heart rate, the duration of the diastolic phase is reduced. Next slide, please. But one other important factor, which is very well known to all of you, is that hypertension is associated with an increased sympathetic activity. And in turn, sympathetic activity is related to heart rate. These are data from our laboratory in which sympathetic activity was measured either by directly measuring the number of sympathetic bursts from the peroneal nerve or by plasma norepinephrine. And you can see that the greater was heart rate, the greater was sympathetic activity. Next slide, please. And particularly when heart rate is elevated above 80 beats per minute, these are data from Professor Grassi from our laboratory in Milan. You can see that when heart rate, both clinical heart rate and 24-hour heart rate is above 80 beats per minute, well, the increase in sympathetic nerve activity measured by microneurography is particularly increased. So 8 beats per minute seems to be the cutoff value above which there is a disproportionate increase in sympathetic activity, with all, of course, the diagnostic and therapeutic consequences this may have. Next slide, please. Now, this is just evidence that in each type of hypertension, sympathetic activity is increased, both when sympathetic activity is measured by plasma norepinephrine, when it is measured directly by microneurography, and when it is measured by the technique discovered and set by a very well-known investigator, Professor Esler from Australia, by norepinephrine spillover. And of course, it's obvious that heart rate is one of the factors being responsible for the sympathetic activation which occurs in hypertension. Next slide, please. And sympathetic activation in hypertension has a number of adverse consequences. For example, a deleterious effect on organ structure and function. And again, let me limit this to one example, which comes from arterial distensibility, or the reverse, arterial stiffening. Now, we did do a number of studies, both in animals and men, in which we look at arterial distensibility before and after removal of sympathetic influences, either anatomical removal, sympathectomy, or functional removal. And in some cases, this was done in rats. You can see that any time sympathetic activity influences were removed, there was an increase in arterial distensibility, which means that when it works, sympathetic activity has a stiffening effect on the arteries, possibly because of a state of contraction of the muscle, also muscles in the arterial wall. And in the end, as I mentioned before, this organ damage becomes clinically overt by clinical events. Next slide, please. And this is shown by the relationship which has been reported in several conditions between the level of sympathetic activity and the risk of death or disease. In heart failure, for example, the greater is the level of norepinephrine, the greater is the chance of dying. The same for stroke, post-stroke condition, the same for renal failure. In sympathetic, in hypertension, this type of evidence is not yet available because, of course, it is very difficult to be collected. Next slide, please. Well, because of these very important reasons, guidelines in the last 10 or 15 years have insisted very much on the need of measuring heart rate accurately. And this is the sentence which was reported in the 2018 guidelines. That is that heart rate measurements should always complement blood pressure measurements. Next slide, please. And next slide. Measurements of heart rate should be as accurate as measurements of blood pressure. And in a review, in a consensus document, which was published a number of years ago, many conditions which are needed in order to have correct measurements of clinic heart rate have been reported. But the important factor is that indeed we should have accurate measurements of heart rate anytime we measure blood pressure. Next slide, please. And when this is done, it is important to notice that the number of people with hypertension showing a heart rate which is above 80 beats per minute, that is the level at which sympathetic activation is particularly marked, is by no means marginal, is greater than 30%. So we do have to deal treating hypertension and diagnosing hypertension with about 1/3 of the patients showing not only a blood pressure elevation, but also a heart rate elevation. Next slide, please. Now, the last question I have to deal with is, of course, should reduction on elevated heart rate be part of an optimal management of hypertension? Next. Well, there is evidence in favor of this, although the evidence is not yet, I would say, complete. We'd like to have better evidence in the future, but the one we have is very suggestive that reducing an elevated heart rate may add to the benefit of reducing blood pressure. These are data from a very well-known trial done several years ago. It was the INVEST trial. And what you're seeing here is that there is a relationship between the reduction in heart rate and reduction of cardiovascular events during antihypertensive treatment. In this particular study, what was shown was that the achieved heart rate value at which the beneficial effect was maximized was around 60 beats per minute. And now in other studies, the value has been different. 65, 66 beats per minute has been the achieved value at which the maximum protective effect of a reduction in heart rate was observed. Next slide, please. I think most interesting data in this context have been a very recent meta-analysis. I participated in the meta-analysis by the guidance of the meta-analysis was by a very well-known meta-analyst, Professor Tomopoulos from Greece. Now, the data were obtained in randomized clinical trials, something like 170 studies, 170,000 patients. And you can see that a reduction of heart rate from these studies of about 8 beats per minute was associated, when the data were considered all together, by a significant reduction in a number of cardiovascular events, either fatal events and non-fatal events, together with a significant increase in the number of side effects leading to treatment discontinuation. This is what happens in all trials, and it is probably due not to the effect of reduction of heart rate per se, but to the effect of the drugs employed. But what was done in this meta-analysis and was interesting was looking at what happens in trials in which there were minimal effects on blood pressure, something like 0.2 to 0.4 changes in blood pressure. And you can see that the effects were less evident, but for example, reduction in coronary disease and reduction in all-cause death remained significant, even in these studies in which there was presumably no major effect by reduction in blood pressure. Next slide, please. What I like very much, however, is a post-hoc analysis of the value study, because it takes into account very nicely, I think, although with the limitation of a post-hoc study, what happens combining reduction in heart rate with reduction in blood pressure as far as the incidence of cardiovascular events is concerned. There were 4 groups in which what was done was to see what happens when there is only reduction in blood pressure, only reduction in heart rate, or combined reduction in heart rate and blood pressure. And this is shown in the dashed black line, and you can see that the incidence of cardiovascular events was minimal when the effect consisted in both a reduction in blood pressure and both a reduction in heart rate. This study was conducted by very well-known investigators for hypertension all over the world, Professor Steve Julius. Next slide, please. Then, final point is, of course, how should we reduce heart rate in hypertension together with blood pressure? There are several possibilities. One is, as you know, ivabradine, which only reduces heart rate, no other major effect. Central agents have a very small reduction of blood pressure as an associated effect. Then non-dihydropyridine agents, they modestly reduce blood pressure. But there is no question that the major drugs we have to reduce blood pressure are beta blockers. And ideally, long-acting beta blockers and cardioselective beta blockers, because there is evidence that beta blockers effectively reduce heart rate and blood pressure. There is evidence from randomized clinical trials that use of beta blockers is accompanied by cardioprotective effects. And there's also evidence that beta blockers are a class of drug which has an effect as sympatho inhibition. Next slide, please. This is just a slide showing that there are several beta blockers, but for example, beta blockers such as bisoprolol, well, they do guarantee cardioselectivity on one side and the long-acting duration on the other side. So they approach to what we look as a good effect for treatment as far as heart rate and also blood pressure is concerned. Next slide, please. But I would like to show you something which is not frequently shown and discussed. Next slide, please. As my last point. That is that the sympatho inhibitory effect of beta blockers leads to a potentiation of the vagal influences on the heart. And we should not forget, although it's not frequently discussed, that increasing vagal influences in the high beta blockers are particularly protective as far as heart failure is concerned on the incidence of sudden death. And let me show you, and I apologize for showing you the old data from our own laboratory, what we did find on this particular point. Next slide, please. Well, and this is that any time sympathetic activity is reduced or abolished, there is concomitantly an increase in vagal cardiac control and influences. Now, these are data in rats by a collaborator, my collaborator in our group, and it shows what is the reflex bradycardic effect of increasing blood pressure with phenylephrine. And in this part of the slide, you can see what happens after sympathectomy. Sympathectomy was obtained chemically by administration the 6-hydroxydopamine. Despite removing sympathetic influences on the heart, well, as you can see, the same increase in blood pressure was accompanied by a markedly greater reduction in heart rate. And this was, of course, due to vagal influences because it was abolished by administration of atropine. So sympathoinhibitory effects of beta blockers are presumably associated with the potentiation of the baroreflex via an action of the vagus. Next slide, please. And indeed, we were able to demonstrate this time in man, by beat-to-beat measurements of blood pressure throughout the 24 hours and modern techniques by which the sensitivity of the baroreflex can be studied, which is the association between an increase in pulse interval and blood pressure, a reduction in pulse interval and blood pressure, or other measures. And with the administration of beta blockers, which reduced sympathetic influences on the heart, as you can see, there was a potentiation of the baroreceptor reflex, which must have been due to a potentiation of the vagal influences on the heart. Next slide, please. And in the meta-analysis I showed you before on heart rate, huge number of people, indeed, there was a clinical confirmation of the potential benefit because when the data were split to see what was the effect of using different pharmacological agents as far as protective effect of heart rate reduction, you can see this effect was present for beta blockers, but not for ivabradine and not for non-dehydropyridine calcium channel blockers. Next, and I think last slide, please. Well, so I think that although it would be nice in the future to have additional data, for what we have today, importance of heart rate for the management of hypertension should not be minimized. And we should be careful, particularly when patients have a heart rate above 8 beats per minute, and try to achieve a heart rate between 70 and 60 beats per minute, ideally probably 65 or 66 beats. Thank you very much for your kind attention.
Thank you, Giuseppe, for your excellent presentation. And we would have discussion after the next presentation given by Professor Yuqing Zhang. So let me introduce Professor Zhang to give the next presentation. Professor Zhang is Professor of Cardiovascular Medicine in Fuwai Hospital at the Chinese Academy of Medical Sciences and Peking Union Medical College in Beijing, China. He's the Vice President and Secretary General of the Chinese Hypertension League, and he's also a member or in the leadership of many Chinese societies of hypertension and related diseases, especially obesity. So he's also a fellow of the European Society of Cardiology and a fellow of the International Society of Hypertension. So we would have Professor Zhang to give a presentation entitled "The Beta Blockers in the Treatment of Hypertension with Elevated Heart Rate, Tracing the Evidence-Based Journey from Mechanisms to Clinical Control of Hypertension." So Professor Zhang, please.
Thank you. And thank you, Ji-Guang, for your kind introduction. And it's a great honor to have I'm here to give the lecture together with Professor Menchia. And also very nice to see many of our friends online. So my topic today is on the treatment with beta blockers and the patients of hypertension and elevated of heart rate, which have been discussed previously by Professor Menchia. It's always interesting and very informative to have Giuseppe here together with us to share his insight, very important insight. So the current situation in the management of hypertension is that we have very high prevalence, and it seems to be that the patient is relatively younger onset, and also very not a very good control in the population level, especially in the young adults, because currently we have more than actually 245 million patients in China with hypertension, and many of them are young patients, because the consistence of hypertension populations of younger subjects is increasing during the past few years. And also the control rate is relatively low, and because of the mainly because of the younger populations who have a relatively lower control rate, and also the number of patients of younger subjects increased. It seems that this is one of the reasons explained for the lower control rate compared to the previous survey carried out in maybe 10 years ago. So now the control rate is about only 12% in the whole populations of hypertension, but in the previous survey about 17%. So this is not very good change in the management of hypertension nowadays in clinical practice in China. So these data needs to be analyzed more precisely in the near future. And also, we also have the analysis on the elevated resting heart rate in Chinese hypertension patients in the survey. It seems that very high heart rate in patients with hypertension in China, around 55 or 56%. And the heart rate was higher than above 75 BPM. And the mean heart rate is around 76 BPM in patients of hypertension in China. And also in China, the elevated heart rate linked to poor blood pressure control rate in the Chinese studies. This study also was carried out. It was a post-hoc analysis of the Chinese hypertension survey in 2015. Only 10 years ago. It seems that the higher control rate, the blood pressure control was become poor. That's the very current situation. It seems that this is quite bad control in patients with higher heart rate. Also, this data have been shown by Menchie just now, the transit on target study, the post-hoc observational study on the randomized clinical trials. We still have some idea to show us the higher control rates. With the higher control rates, that the cardiovascular events and cardiovascular deaths could increase in patients of hypertension. This also implies that the we should control the heart rate more strictly in the patients with hypertension. Another study from Kailuan analysis. Kailuan is small, actually is a place in Tangshan near Beijing, just 100 kilometers, that's 120 kilometers away from Beijing. They have done a very good study, quite long follow-up with the many workers, and this data from their analysis showing that higher resting heart rate linked to increase the all-cause mortality in patients of hypertension. Also have the similar result shown in the on-target transit trial. Then also CSPPT study also have their post-hoc analysis in patients of hypertension, in about 10,000 patients of hypertension. And they also shown the similar effect, showing that the elevated resting heart rate is increased with increased the mortality risk in patients of hypertension despite with well-controlled blood pressure. Also, we have cut the points is 80 BPM compared with 75 to 80 BPM. They're showing that the significant differences in the development of cardiovascular events compared either in patients with even in patients with well-controlled patients of hypertension. when patients are lower than 140 over 90 mmHg. But in the patients with a higher high blood pressure, the did not show the similar results. So also in another study in China, also they published the heart rate in rest heart rate. It's also shown the similar effect in the elderly subjects with a higher quartile of the subject with the higher heart rate. Cumulative incidence of cardiovascular events was higher than those with the other uh, patients with relatively lower heart rate. And the guidelines, and in the recent published guidelines in the ISH guideline, ESH 2023, or in the guidelines in Chinese hypertension guideline 2024, all the unanimously is recognize or recommend that the resting heart rate higher than 80 BPM is an important factor affecting cardiovascular prognosis in the patients of hypertension, and also emphasize the importance of not only measure heart rate, but also taking into account in the control heart rate in the management of hypertension. In a spring study, also they find that reduced the heart rate that was correlated with blood pressure lower with lower cardiovascular events and improve the survival. And also find that these with the heart 1.6 BPM reduction of resting heart rate linked to 20% lower composite endpoints risk in the overall population, which is a very important finding in this post-hoc analysis in the SPRINT study. And also we realized that Giuseppe have mentioned that this important meta-analysis, the targeting on heart rate 65 to 70 per BPM can reduce the cardiovascular events and cardiovascular mortality in patients with hypertension, and also in patients with cardiovascular disease patients. So this is very important. The most recent findings from the lowering heart rate can bring the benefits of in the patients of hypertension and cardiovascular patients. And the second part of my presentation is on the heart rate management in hypertension. We also face up to some dilemmas and try to find some pathways to optimizing our control. This is the philosophy. Actually, this is the philosophy of the recent Chinese hypertension guidelines, because many patients of hypertension or high blood pressure can just a manifestation of underlying diseases, and also we should try to find this mechanism or underlying pathophysiology so as to control blood pressure much better, and also not only targeting on their relatively strict blood pressure level, but also emphasize on the importance of overall management of the disease. This means that we should control not only blood pressure, but also control the risk factor and control the targeting on the treatment of target organ damage or hypertension medial organ damage, and as well as the end-stage diseases. That's on the stage control policy. The most important thing is that we try to find the mechanism of underlying diseases of hypertension or the diseases manifested as the elevated blood pressure. In traditional pathway is to try to find that the secondary hypertension, primary aldosteronism or renal artery stenosis. But not only that, because even in primary hypertension, nowadays the concept that we still have some underlying mechanism or underlying clues to find to support the finding some pathways or solutions to try to targeting on these mechanisms so as to control their blood pressure. which means that with most many patients we have that sympathetic over the activation, and we can find this subject with the high heart rate and the high something related to this sympathetic activation, and to try to find some way to control that. This is the policy or the philosophy of the recent guidelines in the Chinese hypertension League, published in 2024. And not only that, but also in the European Hypertension Guidelines, European Society of Hypertension Guidelines 2023 show the similar philosophy in the management of hypertension, but also emphasized on the etiology, classification, the management of hypertension, trying to not only based on some evidence, which is not much that's before, because we analyzed the data from the high grade evidence. Only about 20 to 30% of the recommendations based on high quality clinical trials, but most of the recommendation actually based on observational studies or etiological mechanism studies. This is the current situation in the many guidelines, even in most, even many other guidelines, American guidelines or the Japanese hypertension guidelines, also have to face up to the current dilemmas in the recommendation they're given, because not many guidelines are very based on quite strong evidence based on clinical trials, but also have to face up to the current situation, which may give recommendations on the pathophysiology. This is also a similar concept from the Chinese hypertension guideline, the European Society of Hypertension guidelines. So the current situation that the elevated heart rate may be explained, or actually may reflect the sympathetic overactivation, which will also serving as the independent cardiovascular risk factors, and also that in the management of hypertension, we should also taking into account how to give better management on the overactivation of sympathetic drive. This is current actually based on the typing policy treatment of the management of hypertension in China, and also actually in the younger or middle-aged populations of hypertension, whatever in China or in other parts of the world, they actually one of the most important mechanism is the sympathetic over the activation, because this may explain as more as 70. Around 64% of the population, they have this kind of pathophysiology, serving as the development of hypertension in patients with under 40 years of age. And also in patients with the high heart rate and low control, in trained patients of hypertension, we also have some these gaps from the guidelines, because many guidelines only emphasize on the management on the measure the heart rate, but not targeting on the treatment of this problem, because there's some gaps between the evidence and the clinical practice. Even in patients with uncomplicated hypertension, the guideline recommended target around 60 to 80 BPM. In patients with hypertension with coronary heart disease, they recommended relatively lower target in the heart rate. But even in patients with heart failure or HFrEF patients, a recommendation of less than 70 BPM is recommended based on the real-world real-world evidence, which is not quite strong, although there are some new evidence supporting relatively stricter heart rate control, but still now is the current situation. But nevertheless, we have a lot of new evidence or new studies to support that the more new beta blockers can be used in the nowadays clinical precision therapy in patients hypertension. and also in the ideally, the antihypertensive agent can bring down the blood pressure and lower the heart rate to a target level, and also control the other target organ damage or hypertension-mediated organ damage. But nevertheless, only in most of these in 6 types of antihypertensive agents listed here, only beta blockers have shown the effects in lowering the effective lower blood pressure, and also without lower the cardiac output, also very good control in heart rate, and also in the control of sympathetic overactivation, and also some effects in the inhibition of RAS activation. And also, it's very important to note that in the recent guidelines, in the ESH guideline published in 2023, that the beta blockers return as the first-line therapy involving recommendation which reinforce blood pressure and heart rate management role in the treatment of hypertension. That's because everybody knows in this field that there are a lot of debate in the beta blockers, because maybe in the ASCO study or in the LIFE study compared to ACE inhibitor or ARBs, beta blocker cannot bring down the cannot effectively reduce the incidence of stroke or even other cardiovascular diseases. But nevertheless, we have to face up to the very important evidence to find that the only beta blocker can to reduce the cardiac arrest, the sudden cardiac death. This is one of the explanations of the beta blockers can reduce the overactivation of sympathetic drive, which is one of the important mechanisms in the development of hypertension, as well as the complications. That's also we have to consider that the typing treatment strategy in our guideline, Chinese hypertension guideline, also recommend that the beta blockers should be used as the initial treatment or a first-line treatment in the treatment of hypertension, because there are a lot of indications. So here is the very famous review drafted by Professor Menchen and his co-workers, which highlights the importance of the use of beta blockers in many patients with indications. And actually, in nowadays clinical practice, a lot of patients with hypertension have these many indications in which beta blockers can be properly used in this subject, because these beta blockers as a antihypertensive agent can effectively lower blood pressure, whether it's systolic or diastolic, very effectively, and also shown the important evidence so important evidence that beta blockers have a superior or equivalent cardiovascular disease or death outcomes. Lower blood pressure and heart rate can bring down the incidence of cardiovascular events, and also that continuous blood pressure heart rate monitoring is of vital importance, because heart rate serves as actually a simple indicator of beta blocker adherence, because this retrospective studies linked to shown that beta blocker levels they have tested the drug levels on the serum, and shown that with the beta blocker levels are higher blood pressure levels, that seem to be at that the clinical heart rate was relatively reduced, can be consistently controlled in patients with resistant hypertension, and it's shown that with the higher adherence, the effective lower blood pressure can be achieved. But Nevertheless, the beta blockers are not all the same because these the agents have the class effect, but we also have to consider that there are heterogeneous in the use of these kind of beta blockers because some agents have maybe the short duration time and not cardiovascular selective. But nowadays, clinical practice, we should use the long-acting agents and with the effects of the cardio selectivity. And that's the current recommendations in the Chinese hypertension guideline, also in the consensus document 10 years ago in the European Society of Hypertension, and also recommend that long-acting beta blockers are recommended, such as bisoprolol, uh, should be used in the clinical practice. And also the meta-analysis carried out published in the European Heart Journal some 5 years ago also shown that bisoprolol is more superior in the lower blood pressure as well as heart rate compared with other beta blockers. Whatever also this data carried out in the it also investigated the clinical heart rate and also ambulatory heart rate with the with this meta-analysis. From the real world study that beta blockers are associated with lower long-term mortality compared to other beta blockers. And also in the guidelines also recommend that single pill combinations so in the nowadays clinical practice, more more SPCs have been developed. Most SPCs are RAS blockade with calcium antagonists or diuretics, but also in the in nowadays clinical practice, we have newer single pill combinations, beta blockers, and calcium antagonists. They also can be recommended as the uh, preferred use combination treatment in the treatment of hypertension in China. So also in China, we have now the bisoprolol and amlodipine single pill combination available. Market can be the manipulation can be used can be given this kind of combination because the bisoprolol has the effect of lowering the sympathetic nerve activation and also have the effect in lowering the inhibition of the RAS blockade. Dual effect in the these two mechanisms, hypertension, and also combined with calcium antagonists and nolipine, which can also have the effect of dilating the heart rate, which can also both can lower blood pressure levels. So it's the dual therapy with triple action. With these one quite important mechanism in the management of hypertension, and also in the real world study, the bisoprolol, nolipine and nolipine show were the very effective very effective effects in lowering blood pressure as well as heart rate, and also have very relatively better adherence in comparison with two pill combination, free combination treatment. And also this kind of SBC steady control the heart rate with no excessive bradycardia concern. So it's a safety concern. So also quite okay in the use of this kind of SBC. So sinus rate less than the bradycardia relatively low in the treatment with this single pill combination. Just around 60 8 BPM, which is quite similar to the recommendation recommended by the Giuseppe just now, 65 or 66. So it's actually my summary is that our key finding is the current situation, management hypertension in China is quite serious because we have relatively high prevalence of hypertension and also low burial control rate, actually 12 or less than 13% of the patient controlled, and the heart rate control is not so very not satisfactory. for all patients for hypertension, we should measure blood pressure and resting heart rate at the same time. And also the excessive sympathetic activation drive both hypertension and the elevated heart rate. We try to focus on these situations, lower blood pressure as well as heart rate. And most importantly is the control the sympathetic overdrive. This actually in the nowadays clinical practice becomes very crucial. And also beta blocker, especially bisoprolol, single use, and also use in single pill combination with amlodipine is a preferred choice in lowering blood pressure and well as heart rate, and also have that this very safety profile and very good adherence. Now we still have many choices, but nevertheless, we should also focus on the most important thing, trying to lower blood pressure, and as well as this type 1 damage. And also we have many choices. Beta blockers is one of the important one. We should use them with a more favorable way. Thank you for your attention.
Thank you, Yuqin, for your excellent presentation. I'm sorry, I'm going to the airport, so I would have to participate in the meeting in a car. So now we already had these two presentations, and we would have about half an hour for discussion. So we are very happy to have two distinguished professors to give expert discussions, ask questions, and give some answers on the use of beta blockers in the management of hypertension, of course, by controlling both blood pressure and heart rate. So Professor Ma and Professor Song, please so let me give a brief introduction. Please show the slide. Yeah, Professor Ma is a professor of cardiology in the Department of Cardiology in Tsinghua Changgeng Hospital, which is a affiliated hospital to a very famous Tsinghua University. And she has been working in the field of hypertension since many years ago, and had a lot of achievements. So next, Professor Song. Yeah, Professor Song is a professor of cardiology and also chief physician in the first hospital, Dalian Medical University. She's also a senior cardiologist, has been contributing a lot of research work in the field of hypertension and related diseases, for instance, heart failure. So Dr. Song will also give us some discussions. So first, Professor Ma, please.
Thank you. Thanks for Professor Wang's introduction. And today is very my great honor to be here as a discussant to join this seminar. And the Professor Manshia and Professor Zhang has given us a wonderful presentation and lecture, and the basic from the mechanism and to the clinical practice, we have learned a lot. And during the lecture, I have think a lot, and to our clinical work, there are still some questions we could originate from this topic. The first question is I want to ask Professor Manshia. From your lecture, you we can know that resting heart rate is always what we can use to measure and to evaluate the sympathetic nervous system activity. But what do you think about other parameters about heart rate, such as the heart rate during exercise and also the heart rate variability? These parameters we can also get from our 24-hour heart rate monitor. So because some patients would ask us, this is really a clinical question. The patient asks us during the resting measurement, the heart rate is normal, but once they exercise a little bit, the heart rate will increase a lot. So how can we deal with this? And the second question is for Professor Zhang. During your lecture, in fact, I noticed you also mentioned the mechanism of for our hypertension. The sympathetic nervous system is one of the important mechanism, and the other mechanism is the fluid retention. As Professor mentioned just now, the fluid retention is also a reason for heart rate increase. So how can we deal with those hypertension patients, especially for the young and middle-aged hypertension patients? Those patients also they might have also both have the sympathetic nervous system activated, also has the fluid in retention. We can use beta blocker to decrease their heart rate, but how to deal with the fluid retention? If they come to heart failure, most hypertension patients did not come to heart failure, but we know during heart failure, we could not use beta blocker before the patient come to dry body weight. So even in some hypertension patient, we can see if we use beta blocker for a large amount, a large dose, they might come to heart failure. For these questions, I have one way to dissolve it is we can use diuretic, but according to our guidelines, beta blocker and diuretic is not the first recommended anti-hypertension drug combination. So as you mentioned, we recommend beta blocker with CCB. But what about how to deal with those patients I mentioned? Both has activated sympathetic nervous system and also have fluid retention. So these the two questions for you.
Giuseppe, please.
Yeah.
Well, there are many questions, all interesting. The first question is, can we refine the indications for beta blockers? That is, add to the available clinical phenotypes. And there is room for research here because I think we have very few data whether 24-hour heart rate is better as a prognostic factor compared to clinic or office heart rate, whether heart rate variability has an independent prognostic value, like we know it happens for blood pressure variability. And then thirdly, whether nocturnal heart rate values and nocturnal heart rate variability have an independent prognostic value? I think they are very interesting questions. They have been addressed in some studies, but the evidence is obviously not enough. In our study, for example, above 80 beats per minute office heart rate, we also measure 24-hour heart rate values and found more or less similar value as for office heart rate, but we didn't look in particular to whether one was more predictive than another. Then we have from Professor Palatini from Padua University. He has done very good studies on heart rate, and he found a predictive value of nocturnal heart rate variability, which is interesting. But again, I think this is one example. I think we need more evidence. But the question is well posed. We need to identify some further specific phenotypes based on heart rate, which may give us a better view, a more precise view of what we're doing. Although the basic question that in heart rate individuals is better to in individuals with a heart rate elevation, I think we have to reduce heart rate definitely, and that for this purpose, beta blockers are, of course, the best drugs we can have. What else? I mean, one other, but I think the other questions were not directed to me. Am I wrong?
Yes,
For
just this question to me on the fluid
because there were many questions.
retention.
One other question I captured, then I stopped talking, is that I mean, the colleague said beta blockers and diuretics are not a good combination. Well, my God, I'm not sure I agree with this, because the history of hypertension is largely based on trials in which the drugs which were used were diuretics plus beta blockers. And I think that the evidence that this combination is protective is unequivocal. So maybe, of course, we have to consider this metabolic effect that this combination may have, but this can be true for some beta blockers, but not for other beta blockers. But I mean, the evidence that this is effective in lowering blood pressure and it is protective against hypertension-dependent cardiovascular events is unequivocal. My bias is that antihypertensive treatment has to be liberal. We fortunately have quite a large number of good drugs, and we have the possibility to select them according to the patient demographic or clinical phenotype, and we have to consider this a wealth.
I would agree with Giuseppe's point that we should also focus on the use of a proper use of a beta blockers and even diuretics in patients with fluid retention. Even in patients, I think one of the most important examples is the patient with heart failure. We use this kind of agents quite often, actually, in our clinical practice. That everybody agrees with this kind of use. That actually, I think even in patients without heart failure, we should also consider to use the beta blockers to control the sympathetic overdrive. Then is one of the most important mechanisms of patients for hypertension, especially in the younger populations. And also, I think is one of the important issues indicated by Giuseppe in his first part of lecture is on the heart rate and also sympathetic overdrive in the patients with the metabolic disorders in the obese patients or in patients or even diabetes. That also highlights the importance of the not only patients with the sympathetic overdrive, but also in these patients, some patients will have some the fluid retention. That's something we have to consider. in the management, overall management of this kind of patients, but maybe not use the diuretic patients, but also we should also focus on the newer agents, the novel agents with SGLT2 inhibitors or GLP-1 inhibitor active agonist, that this kind of novel agent may have some more efficacious evidence support the reduced sodium retention. And we can find that even SGLT2 inhibitors have this effect in lowering nighttime blood pressure, which is maybe one of the mechanisms that can play in lowering the sodium intention in this kind of subjects, even in patients with obesity or diabetes. It's just one of the explanations. That's we talk about this retention, but maybe not, or we may not recommend to use all patients use diuretics, but we may select some novel agents targeting now these mechanisms, that maybe these novel agents can give us some new ideas in the management, future management of hypertension and typing philosophy. Thank you.
Thank you.
Okay. Yeah,
Thank you.
Professor Song, please.
Oh, thank you. Thank you for the introduction of Professor Wang. And I think it's a very cherished opportunity. I have learned a lot from two professors. And I also have some questions. I think I will ask them one by one. And first, I want to ask the Professor mention, as Professor Zhang described, that there are a lot of young and middle-aged hypertensive patients in China. And sometimes they are, the mechanism of the hypertension of these patients may be related to the sympathetic nervous overactivation. So I think the beta blocker is suitable for young and middle-aged hypertension. And I think for some of the male patients, sometimes in the clinical, they will ask if I have the beta blockers, whether it's affected the sexual function, especially for the combination of beta blockers and ACE inhibitors. So I want to know how to explain for this kind of questions to your patient.
The question is addressed to me?
Yes.
Yes. And I mean, the question is, how can we explain the rationale? What is the rationale of combination of an ACE inhibitor and a beta blocker? Is this the question?
Sometimes the patient asks the beta blockers will affect the sexual function, especially the combination.
Yeah. Yes, okay. Well, that's in general. I mean, the recommendation of recent guidelines, not only the European guidelines, but I mean, I think all guidelines, to make large use of combination treatment, and including use of combination treatment as first step treatment, well, is based also on the fact that in combination treatment, drugs are used at lower doses, and this reflects into a better tolerability, which is, of course, a fundamental component because tolerability is closely related to adherence to treatment. So using in combination treatment also beta blockers at lower doses, so this may help also as far as sexual function is concerned. But then there are some new beta blockers, I mean, their effect on sexual function is definitely clearly less than for all the beta blockers. And third, please consider also that some of the older conclusions about sexual function were based on uncontrolled studies. In this regard, there is an interesting study which was made by an Italian group and published, I think, more than 20 years ago, 25 years ago. And in this study, what they did, they looked at sexual function in three different conditions. One condition was open and informative condition. That is, patients were informed of the potential negative effect of beta blockers on sexual function. Then the second one was single blind, and the final one was double blind, and patients didn't know. And there was a very clear and large difference in the number of people complaining of sexual dysfunction in these three conditions. I mean, so part of these side effects are not related to the drugs itself, but this is true probably for all side effects, but they are related to the psychological aspects of treatment. I think this would be my answer, but I would add to this something which came to my mind, but in fact related to the previous important questions. That is, can we identify new phenotypes for beta blockers? Well, we described, as it is mentioned in one of the three questions, at least 50 conditions in which beta blockers are commonly used, not because of evidence of protection, but because of anti-symptomatic effect. I think the mention of this in the guidelines of the European Society of Hypertension was done because, I mean, this makes beta blockers first-step drugs de facto. How can you really give up a use of beta blockers when there are so many conditions in clinical practice in which beta blockade is part of the treatment? But as far as specific phenotypes are concerned, it comes to my mind that there is other phenotypes. For example, one was mentioned is people having an increase in heart rate, excessive increase in heart rate by standing or by a very mild exercise. And I think this probably reveals a sympathetic activation during standing and during exercise, excessive sympathetic activation. I would consider this an indication for beta blockers because of maintenance or preservation of quality of life. And the same for another phenotype, which is orthostatic hypertension, which is similar to orthostatic tachycardia in a way, but is characterized by an increase in blood pressure. Even in this condition, probably we are facing an excessive stimulation of the sympathetic nervous system, and therefore beta blockers are indicated, in my opinion.
Okay, thank you. Thank you for your excellent answer. Next question is for Professor Zhang. And as the heart rate is an indicator of the sympathetic nervous activities, and renal denervation device was proved last year. And do you think the heart rate is an indicator for the patient who is suitable for renal denervation?
Yes, Professor Song. Thank
Professor
you.
Zhang.
Thank you for your very important question for the heart rate as the indicator of the RDN treatment. But I think it's it's quite reasonable because renal denervation is a kind of treatment for patients with actually sympathetic overdrive as one of the most important mechanisms of patients with resistant hypertension. Actually, I have discussed with discussion with late Professor Steve Julius several years ago when he was in China to pay a visit. At that time, the third trial of the renal denervation was carried out with a negative result. But when we have reviewed the data on these simplicity hypertension 3 study, that we still find that in patients with relatively higher heart rate, and which means that the maybe these kind of patients over sympathetic overdrive is one of the most important one of the mechanism of these patients with resistant hypertension, because but nevertheless, it should be the only one indications for use that this earlier treatment, but not all, because we still have to consider about the blood pressure per se, because the selection of the appropriate patient to do the trial, to do the procedure. But nevertheless, I think it's reasonable to consider that high heart rate may be one of the thing we should consider in the selection of these procedures to carry out in this subject. And also because the mechanism of sympathetic overdrive will be in the two parts. One patient, why we mentioned the younger subjects, because in the initial stage of development of hypertension, sympathetic overdrive is one of the important mechanisms. But in the development of the hypertension, the RAS blockade, RAS activation is become prominent. And it also at the late stage of hypertension, such as at resistant hypertension phase or refractory phase, that or sympathetic activation become again is become more prominent. But nevertheless, we should know that the heart rate is an indicator of this overdrive of this phenomenon, but not all. That's something we have to consider. So what I want to say that even the patients with bradycardia, and also some indications for showing that patient resistant hypertension, we also can consider to use early in the treatment of this kind of patient because we have to control the blood pressure. Thank you.
Thank you for your excellent answer. The reason why I ask this question is that in the past months we have five patient five RDN patient, and all these five patients have increased heart rate. They have a lot of high dose of beta blockers, but after the renal denervation procedure, the heart rate was decreased, but the blood pressure reduction was very small. So I also have the last question. Because more and more elderly patient with aortic valve stenosis, they can they are now perform TAVR procedures, and in the procedures when the valve was released, we have to increase the heart rate into maybe 180 to make the blood pressure decreased. So sometimes this kind of patient have beta blockers before the procedure. So after we reduce the heart rate without pacemakers, the blood pressure increased slowly. So I wonder, for this kind of patient, for TAVR patient, is it necessary for this kind of patient to stop beta blockers before the procedure? Do you have any experience to share?
Actually, to me, I have no experience to doing this kind of procedure. Other teams, there are two teams in our hospital carried out PIVR, which very experienced doctors. But I don't know anything about the procedures. So I think it's maybe. Giuseppe, do you have any idea on this procedure?
No, but I'm always impressed by the questions which come up. On which the evidence is not available. So really what to do is left to the judgment and to the wisdom and the knowledge of the individual doctors because of lack of evidence. And there are very many conditions of this kind. This is one, of course. So what to do? Can this be systematized? what to do. I'm not aware that then this issue has been taken up by any guidelines.
Okay, thank you. Thank you.
Are there more questions? No? If not, I should thank you all. Thank you, Professor Mensch. Thank you, Professor Zhang, Professor Ma, and Professor Song, for your presentations and discussions. I'm going to a very far south province at late midnight. So yeah. So we had very fruitful discussions on the use of beta blockers and on the measurement and management of heart rate and hypertension. So I think we had a very very strong data in supporting the use of heart rate and beta blockers in the management of hypertension, because we apparently need all classes of antihypertensive drugs to improve the management of hypertension, especially these days in China. Many people have overactivation of the sympathetic nervous system, so we terribly need beta blockers in controlling hypertension by the use of its very typical heart rate slowing effect. So we are very grateful to Professor Mensch for his great work in publishing that very comprehensive and informative review on the use of beta blockers in many different clinical conditions. So that review actually helped us a lot in China in the in the choice of antihypertensive therapy in the Chinese hypertension guidelines, because in China there is also a small proportion of people who are supporting the American guideline recommendations on the exclusion of beta blockers from the recommended antihypertensive drugs. But we, as a major Society of Hypertension in China, the Chinese Hypertension League, continues to support the use of beta blockers in the management of hypertension in parallel with all the other classes of antihypertensive drugs. So I think this evening we learned a lot, and we should do even better in the future in the management of hypertension in China. So thank you all. I should also thank all the participants for participating in this webinar and online meeting after all the long work. So I should thank everybody for the presentation, discussion, and participation in this webinar. So thank you, Giuseppe. Thank you,
Thank you,
Thank
Giuseppe.
you very much.
Grazie.
Thank you.
Grazie.
Bye
Have
bye.
a good journey.
Bye-bye.
Bye.
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 Bye.